today is on conditions that cause pain around the Achilles tendons. This is usually around the back near the heel. The Achilles tendon is quite a remarkable tendon. This is a common problem, unfortunately. It's called a number of different names. People call it Achilles tendinopathy or Achilles tendonitis. They're all various versions of the same thing. So a bit of information today about the Achilles tendon itself. It's quite a remarkable tendon. It is the largest tendon in our body. In addition, it is the strongest tendon in our body. And when we go for a run, it takes about 12.5 times our body weight. So that explains why runners certainly can have an issue with the Achilles tendon. Now, this is a drawing of the Achilles tendon here and the muscles that make up the tendon itself. So there's a muscle with two heads called the gastrocnemius, which is the muscles labelled in red there. And then there's the soleus muscles, which are labelled in blue. So the image on the left is you're looking at your leg from the side, and the image on the right is looking at your leg from the back. So you've got the gastrocnemius and the soleus, and they make up the Achilles tendon, which is labelled there in yellow. And as we've seen, it's quite a powerful tendon. Now, the tendon attaches onto your heel bone, which is known as the calcaneus. And we can see the calcaneus here. And then if you see that area in pink that's labelled, that's the area known as the watershed line. It's about 4 to 6 centimetres from the heel, and we think people have problems with the Achilles because the blood supply there may not be as good. Now, a couple of risk factors for Achilles tendinopathy. If you do running or jumping sports, you are certainly at risk for having an Achilles tendon problem, about 10 times the risk of your average person who doesn't do that activity. If you have a family and member of the family that's had it, there is 5 times the risk. If you have something called abnormal subtalar range of motion, which is the joint between the yellow and the blue there, then that can also cause an issue with the Achilles. Or if you have what we call reduced or increased dorsiflexion, meaning that you either move the ankle up too much or not enough compared to the average person, you can have an issue with the Achilles. Now, in terms of Achilles problems, there are 2 types. There's insertional Achilles problems and non-insertional Achilles problems. The non-insertional Achilles problems make up 65%, and the insertional Achilles problems make up about 35%. Now, this drawing here is a foot from the back, and labelled in red there is the Achilles tendon, and the C-shaped marker there is your heel bone known as the calcaneus that's looking from the back. Now here we are, we've got that picture once again from the back. In your insertional Achilles tendonitis, the area where you will have pain is down where the pink label is, down at the back of the heel. If you have the non-insertional Achilles tendonitis, you get pain in the mid-substance of the tendon in that yellow area there. So you can certainly compare that to where you get pain yourself, and that'll help you maybe get a diagnosis. In terms of symptoms of non-insertional tendinopathy, remember the non-insertional is that area about 4 to 6 centimetres above the heel, which makes up about 65% of cases. We have that pain that is just in the mid-substance of the tendon. People can get morning pain or stiffness. They can also get pain which is provoked with activity, particularly activities where you're testing it out, like on stairs or in running. And a few other things that you may also find is that the swelling of the tendon itself is bigger than normal. It's usually a bit boggy around the area where it's sore, and you get difficulty with something called a single heel raise. Now what that is imagine your foot's originally flat to the floor, then you get up on your tippy toes with your other leg not helping you at all. That simple test there, you're probably going to struggle with an Achilles tendonitis. So signs and symptoms of the insertional tendinopathy. Now, your insertional tendinopathy, it's at the base where the Achilles inserts, so right at the back of the heel in that pink area. It's less common, makes up 35%, but you also get morning stiffness. You get pain that is localized around the back of the heel rather than the mid-substance of the tendon, and the pain is worse if you're using stairs, running on hard surfaces, all those sorts of things. And you may have had an increase in activity recently, so if you've changed your training regimen, you should go back to your original training regimen or back it off. In addition, the tendon might be really thick around the back there, and it might be really boggy, particularly at the back of the heel. And if you look in this picture here, this person's got a little bump on the side of the heel, so that's where an extra bit of bone can be, which can provoke pain. Now, this here is a picture of an x-ray from the side. The yellow area there is the Achilles tendon itself. In patients with insertional tendonitis, they get something called a Haglund's deformity, which is labelled there with the red arrow, and that's an extra piece of bone that can rub on the tendon. And I'm not sure whether that got there first or whether it was caused by the problem with the tendon in the first place. So what can you do if you've got problems with your Achilles tendon? Well, there's some very simple things you can do which don't cost you a lot of money. You really don't need any simple orthotics. So if you imagine a rock attached to a rope that weighs 50 kilos, right? Imagine the yellow piece is your Achilles tendon. Simply just wedging the rock up takes the pressure off the yellow area, the yellow rope, which is your Achilles tendon. So putting something in your shoe which wedges your foot up can sometimes help to relieve the tension on your Achilles. And they often look like this. They're little sticky things that you put in the base of the shoe. They only raise it probably half a centimetre to a centimetre, but they can certainly make a big difference. Now, the other thing is something called eccentric muscle exercises. And you might say, well, what is that? It's medical terminology, but what it means is an exercise where the muscle is lengthened or stretched out while it's under load. So I can give you an example of where that's applied and how that makes a bit more sense. So if you imagine your average biceps curl activity that someone might do in the gym. Now, when you're curling the dumbbells up, that's called a concentric contraction. That means the muscle is actually getting shorter as you contract the muscle, and you can feel that your muscle bulges, it gets shorter, it sort of crimps up. When you release that biceps curl to bring the arm back out straight, that biceps muscle is actually lengthening back out again, but you're not dropping the dumbbells, and that's because the biceps is still taking load, and that's called an eccentric contraction. So an eccentric exercise means the muscle is lengthening out while it's still contracting. Okay, and these are the types of exercises which you need to do for your Achilles. And there is a protocol for this called the Alfredson protocol. And the way that works is that you get up on your tippy toes on the edge of a step in your joggers with both of your feet. Then you lift your good leg and slowly lower the heel while the rest of your foot is still on the step, and that stretches the muscle out. And you can do this exercise with the knee bent, or do the exercise with the knee straight, and really you should be doing both. And you need to be doing this exercise regularly in order to get a result. And what is usually recommended is doing these exercises at least twice a day, and the amount of reps you're doing is 3 sets of 15 with the knee bent, and then 3 sets of 15 repetitions with the knee flexed. And if you start to get reasonably good at it, you can then increase some weight, and the way to do that is to fill a backpack, and ideally you should get ultimately up to 50 kilos. And that's really, you need to keep going, so it's going to hurt. You need to sort of keep going through that to really get a result. Now, other things you can do, when it really gets really bad, resting, icing the area, taking anti-inflammatories, provided you've had a chat to your doctor that you don't have any problems taking anti-inflammatories, and modifying your training. So if you really stepped it up, you need to back it off, or if you're having issues, you need to slowly reintroduce it, not do large 10-kilometer runs at a time. Now, here we go back again to our to what the percentages of what each of the types of tendinopathy are. So remember, the non-insertional, so in the middle substance of the tendon, makes up 65%, and the area where you get pain at the back at the insertion makes up 35%. Now, in terms of how likely the eccentric exercises that'll work, for the non-insertional, it works in 80 to 95% of people. So most people are going to get better with the exercises if they've got a non-insertional tendinopathy. For the insertional group, the pain at the base of the heel, the exercise is only working about 30%, so 3 out of 10, but certainly if you get away with that, they're definitely worth doing because the other options are generally surgical. So just to remind you again where you'll get your pain with each, the insertional there is the pain around the pink area. We're going to bring in here the non-insertional picture again. There you're going to get the pain over the mid-substance. That's the type of pain that often gets better by doing the Alfredson protocol, those eccentric stretching exercises. Now there are other what we call non-operative measures. They can include steroids, injections around the tendon, but really you should be talking to your doctor about that if it's the case, and something called GTN patches, which are called nitrate patches, and they're something you can discuss with your doctor, but their efficacy is variable, and so hence they really should be discussed. So the question is, what about surgery? Now, if you've got the non-insertional type, this is the one that often gets better without surgery. This is the one that gets better in 85 to 95% of cases just with the exercises and some inserts into your shoes. Okay, and we think that's caused by that poor blood supply in that pink watershed area. Okay, and that's where you're going to get the pain, where we see it on the diagram. Often if this persists, you're going to get an MRI, and the tendon may then need to be debrided, so cleaned up. Sometimes it needs to be repaired because there's a big tear in it, or sometimes it needs to be reconstructed by using a different tendon. And so they're only in the small minority of cases that still persist despite a good at least 3-month go at physiotherapy with those exercises. For the insertional group, where the pain is at the base of the heel, this is what your tendon looks like from the back. So that yellow area there is the tendon, and the white bit there is going to be that calcified rock or the heel bone known as the calcaneus. Okay, we're going to use this example to what we would do in surgery if your pain persisted and you needed an operation in order to relieve it. So if we go back to our diagram there, where the yellow tendon is there, and the Haglund's deformity, which is that bony prominence, is labelled in red. This gives us some clue as what we need to do. So we need to access that bony prominence there, and the only way to do that is to take off the tendon. So here we are, here's the tendon again on the calcaneal bone. Okay, and what we're going to do in surgery is peel it off like a banana. We make a cut in the middle of it and peel it off side by side so that it's no longer sitting onto the heel bone. Okay, it gives us a good look at the heel bone and gives us good access to that bony prominence, which is the Haglund's deformity. And here we are with an x-ray here, so we've taken the Achilles tendon off and now we've got access to that bony prominence there, and we'll be able to see it. And what we do is we remove that prominence so it's no longer there. Okay, and that red line there is is the direction in which we would remove it with either a chisel or a saw. Once that's removed, you can see here in the picture that that's removed there, so that prominence is no longer there to interfere with the tendon. We'll clean the tendon up in the meantime, and then we reattach the tendon back onto the bone. The way we do that is that we use something called a suture anchor. It's a little bit like a screw, but the good thing is it has some strong sutures attached to that screw, and so it looks a little bit like this picture with the screw going into the bone and the stitches going down into the tendon and holding it in place. And then it really is a 12-month recovery in terms of recovering for an operation like that. And the big thing is getting the wound to heal in the first couple of weeks, but really you're in a boot for at least around about 8 to 10 weeks, like this one called a range of motion boot. So Achilles are difficult problems, but a lot of them can be fixed without an operation, and I hope this clears a few things up. Remember, this is only an education, so really you should discuss these with the doctor. But if you want some more information, you can find us on www.hunterfootandAnkle.com.au. Thank you.